Hello everybody, welcome back. Moving right along, we're going to start with Mycobacterium tuberculosis. So there are the fast growers that grow less than 7 days and the slow growers which take more than 7 days. They make scotochromogen, which are yellow pigments in the dark, and the photochromogen, which makes the yellow pigments only after the exposure to light. And then there, of course, are the non-chromogens. It causes tuberculosis only in humans. Mycoplasma bovis, is going to cause tuberculosis from the animals transmitted via raw milk. And M. avium complex, M. kansasi will cause a TB-like disease, but only in HIV patients. All these are going to be found really in the soil and the water. Mycobacterium leprae is going to cause leprosy in humans, and M. marinum is going to cause the skin granulation. It's found in the water. M. ulcerans is also going to cause the skin infections, and these are going to be necrotizing ulcers called Buruli ulcers, and those are both found in the soil and water. M. tuberculosis is an acid-fast bacilli. It's an obligate aerobe, and it's non-spore forming. It's a facultative intracellular pathogen, and it's weakly gram-positive. So the cell wall has a lot of complex lipids, such as sulfatides and trehalose dimycolate, which makes it a bit hard to stain. It's a non-chromogen, and it's a slow grower, and it makes niacin. So there's resistance, of course, to the antibiotics, and it's also resistant to the complement attack. It is also resistant to lethal oxidations. How is that? It survives inside the macrophages, which surrounds it in a granuloma, and it causes something called a caseous necrosis. So these caseous granuloma make the lung kind of like cheesy, Swiss cheesy. The cord factor is going to be your trehalose dimycolate, and it's part of the surface lipid in the virulent strains. It inhibits the leukocyte migration, disrupt the mitochondrial respiration, and oxidative phosphorylation. So this is going to deprive the cell of energy. And it has a serpentine appearance in culture. The reservoir is humans, and it is going to be transmitted via the aerosol, so it can survive 8 months in the air. It's a pretty scary disease. So when you see patients being treated in the hospital, the PPE is almost like space equipment. Like you have to have your own air supply. You can't share anything with the patient. Unfortunately, HIV has increased the prevalence of TB worldwide. And in patients who are treated, it can still remain dormant for years. So how is it virulent, and what are the virulence factors, even though it has no exotoxin or endotoxin or capsule? Well, first, it survives inside the macrophages by preventing the fusion of the phagosome and the lysosome, and by exporting the repetitive proteins and sulfatides and sulfolipids. It also prevents the oxidative killings, and it affects the lungs but can spread, of course, to the other organs. On first exposure, there's no specific immunity because they're all taken up by the alveolar macrophages. And the infected macrophages will secrete IL-12 and TNF-alpha, which are going to recruit the inflammatory cells. So it can progress from primary tuberculosis to something called miliary tuberculosis. This is after the dissemination. So the granulomatous lesions are also called a Gone focus. Those are going to contain your epithelial cells, the giant cells, and the T lymphocytes around the alveoli. The Gone complex is going to be a granuloma with a central caseous necrosis that involves the lymph nodes. The tubercle is a granuloma with the central necrosis, and instead it's going to be surrounded by fibrous tissue. Miliary disease, tuberculosis, is when the mycobacterium has spread, and it causes something called the millet seed pattern. That's why it's called miliary. So it's going to present as a failure to thrive, fever of unknown origin, multi-organ dysfunction, night sweats, and rigors. The extrapulmonary sites are going to involve the lymphatic system, bones and joints, the liver, the CNS, and adrenal glands. But in the majority of the disease, the body actually eliminates the bacterium pretty well. In the latent infection, the bacteria is still viable in the granuloma, and in the primary infection, the bacterial replication is like active. Secondary infection is when the repressed immune system causes a reactivation of tuberculosis from a granuloma, and then the bacteria spread. Primary tuberculosis is going to affect the lower part of the lung, and it's going to cause a cavitary lung disease, so it just punches a hole into the lung. It's going to have a gradual onset, cough, bloody sputum, fevers, chills, night sweats, and presents with weight loss. The reactivation of tuberculosis is going to move upwards and affect the upper part of the lungs. It's also known as Pott's disease. So you use the Tuberculin or the Manitou test or the PPD test, where it's basically testing for a type 4 hypersensitivity reaction. It checks the exposure but doesn't really differentiate the time of the exposure, or whether it's a vaccine or whether it's a active infection. So there's some guidelines, like 5 centimeters is going to be considered positive in an HIV patient, or patients with recent contact with the tuberculosis, or patients with an abnormal chest x-ray. 10 millimeters is going to be positive in migrants from high prevalence regions, such as like Russia, crowded living, healthcare workers. 15 is going to be positive in patients with no known risk factors. So in the chest x-rays, you want to look for the tubercles, the Grand complexes, and the cavitary lesions. You stain the mycobacterium with the acid-fast staining, or Zell-Neelsen, or the Quignon stain. Fluorochrome stain with the auramine rhodamine stain is going to be followed by the Zell-Neelsen stain. Culture has to be pretty particular. It's either the Lowenstein-Jensen medium or the Middlebrooks 7H10, and that can take up to like 8 weeks. You can use a BACTEC detection medium to detect radioactive carbon dioxide, and that takes only 2 weeks. Better yet is the interferon gamma release assay. It's the more specific and timely of the tests. But you can also do PCR or ELISA. So treatments. Treatment's long. You take it for 6 to 9 months, and you take a variety of either like isoniazid, rifampin, pyrazinamide, ethambutol, which are bacteriostatic. And then you have to be wary that these can be resistant to isoniazid and rifampin. The extra resistant or extremely drug resistant tuberculosis is going to be resistant to isoniazid, rifampin, and any fluoroquinolone and a second line drug, which involves either amikacin, kanamycin, and capreomycin. So the prophylaxis is going to be this too, and there is a vaccine, the BCG vaccine, which is a live attenuated bovine strain, not really used in the US. So you got to ask if the patient has come from like Eastern Europe, because they do tend to use that a lot there. That's it for now. Thank you for your attention, and good luck studying.